Hello and welcome everybody to another exciting episode of Side Talks 2.0. As always, my name is Dr. Jack Saxenian, and today I have once again our guest, Dr. Priya Soni, to talk to us about the latest advances and updates about the coronavirus pandemic. And she has some exciting information regarding many of the questions you guys had been asking. So without much further ado, I want to open up the questions for her and get started on this so you guys can get the whole picture about what we know about the coronavirus so far. So with that, please, Dr. Soni, if you could tell us about some of the updates that you think are important for the general public, and then I could sort of go into the more specific questions.
Sure. Thank you so much for having me again. So a lot of time has passed. It feels like every time we do this, it's been years and years because the information is just constantly changing. We're getting bombarded by multiple news outlets, etc. But we are hoping to have more of a conversation about some of the key topics that have come up over the last few weeks with SARS-CoV-2 slash COVID-19. Of course, this is constantly changing data. So what we talk about today may change tomorrow, but we want to talk about some of the hot topics. So let's get
So,
started.
yeah, so one of the big questions people had asked, and because they've been hearing it on the news, is whether they should be wearing masks and what kind of masks they should be wearing, and also should they be putting on gloves, and what would be the proper attire when they essentially walk out of their homes. So can you talk a little bit about that? Because I know there's a little bit of confusion going on based on what CDC is saying, based on what they hear on the news and what they hear from their friends.
Yeah, so basically, a lot of cities in the United States slash the CDC has now put out guidance suggesting that when you're going out and about, if you have the means to wear some sort of facial protection or mask, you should do so. And the reason for this is because we've essentially found more data regarding SARS-CoV-2 being spread from asymptomatic carriers. So what that means is people that have zero symptoms, no fever whatsoever, could potentially be spreading this virus through what we call microdroplets that could be spreading if you're within 6 feet of someone and they're even just speaking or singing or just really close to you. So these microdroplets are a very big potential for risk of spread of this infection. So with regards to the masks, if you're not in the hospital, I really encourage you to use just a cloth mask. I think there's a lot of videos on the internet right now about just using like a handkerchief or a bandana and creating some sort of barrier between your mouth, your nose, and the outside world. And I see some people wearing N95 masks in public, things like that. Those masks are very, very important for healthcare workers. So if you happen to have a box of those, please consider donating them to your local hospitals because we, of course, are in a national shortage of personal protective equipment or PPE. So we really want to save those N95 masks for people in the hospital that are working front lines and would be more likely to be in direct contact with someone who's COVID positive. So try to just cover your mouth. The gloves may not be necessary as long as you're, again, doing really good hand washing. Because remember, this virus has a lipid layer on the outside, so good hand washing is still very effective whenever you come back from going to the grocery store, etc. Think about it. It's like, when we cut grease on a pan that's dirty in the sink, it comes off really easily with just some soap. And this virus is not that hardy once we apply soap and water effectively. One thing I will say about the masks is that you have to be really careful about removing them. And people don't really realize this, that you're more likely to get contaminated by your mask if you don't know how to take it off properly. So imagine that I have a mask on right now. You take it off from your ears, and then the contaminated part of your mask is technically the part on the outside, right? So the part that's been in contact with, other people that have been around you that potentially could be contaminated with their microparticles and droplets. So once you take it off from behind your ears, you want to pinch the mask and fold it from inside out. So the part that your mouth has been towards is towards the outside now, and then you can securely store it in an envelope or Ziploc bag, whatever you have.
So it's really important that people learn how to put the masks on, which is sometimes also an issue because I've seen people who put the mask and it's not over their nose, it's kind of hanging, and it's kind of rubbing up on their mouth and all over. And it's also very, very important how you take that mask off because you're not going to just toss it, you're going to reuse it. So as Dr. Soni said, if you're touching the areas that you later expose it back to the area that goes towards the mouth, you're actually doing yourself more harm than good. So those are really, really great points. And one other question in terms of that, what do you do when you get home? I've had people that say, hey, I'm one of those essential workers, not necessarily in the healthcare field, but working in the grocery. When I get home, what should I be doing in terms of, let's just say, decontaminating myself before I start interacting with my family members? Do you have any suggestions for what people should be doing?
Yeah, that's a great question. Um, if you are working directly with COVID positive patients, you're on the front lines in that sense, you're at a higher risk of maybe potentially carrying some particles on your clothing, but um, we're hoping that you have a good gown or personal protective equipment that is another barrier between you and your scrubs or attire. However, it's personal comfort, right? I have most of my friends just like kind of changing their scrubs or taking them off right outside of the house or even right immediately as they enter, just throwing them in the laundry. It's your personal comfort level. I think the data that we have on transmission of this virus is very suggestive that it lies viable on harder surfaces. So what that means is that on elevator buttons, door handles, things that are metal, it may be viable for up to 5 days. On clothing, that's not like a major uh, form of transmission. So if you rubbed your nose on your clothing, less likely to cause an infection than if you were directly in contact with someone who was speaking towards you without their mouth covered or any respiratory droplets in the air that you may have come in contact with. But really, I mean, all healthcare workers, I think it's good practice just to make sure you change your clothes immediately upon arriving back home, just for other other reasons too. I mean, we're on the front lines, and there's many other bodily fluids that we come into contact with. So,
Right. And so if you're not working in the healthcare and if you're just working, let's say at the grocery store, just coming home, changing your clothes, washing your hands should probably be enough, right? You don't need to Clorox bleach every single part of your body or your clothes.
yeah, you don't have to do that. I mean, just take caution. I think in addition to washing your hands with soap and water and changing your clothes, it's a good practice to also wash your face because you may have dirt or particles, infectious particles that are on your face, and then you might touch your face or touch your face and then eat or something after that without washing your hands. So that's a potential. So really, no one needs to be. I've heard of accounts of people Cloroxing vegetables, using hospital grade soap on their food products. That might be a little excessive, but do what you feel comfortable with within common sense and your means. So
Right. And we just using common hygiene that people generally should be practicing. I think with a little bit more should be sufficient for even for this pandemic. What's going on in terms of our treatment strategies? And they've been hearing the president say one thing, they've been reading the media say something else. Is there sort of a consensus still within the medical field as to what we're doing and how we're practicing in terms of our everyday treating patients, and what should people be expecting in terms of some of these treatment modalities?
Yeah, so that's a really good question, very loaded question. So I guess I'll start with the major question for one of the drugs that the president's been mentioning, which is the hydroxychloroquine. Now, you and I touched base on this drug in one of our other episodes where we discussed the potential use of hydroxychloroquine. Again, just for those who are just coming on, this is a medication that has some immunomodulatory effects. So a lot of people on rheumatoid arthritis or lupus, they are on these drugs for a different reason. And then hydroxychloroquine specifically is an anti-malarial drug. So there have been two major studies. I guess I'll just talk about them briefly that have come out regarding hydroxychloroquine use. So the one that we all hear about is the France study, and the one that there were 80 patients that were non-randomized, which means that essentially the researchers felt that they didn't need to have a control group that received a placebo. They felt very strongly that hydroxychloroquine and azithromycin would work based on their prior studies, that they went ahead and did an 80-person trial where they enrolled people from the hospital very rapidly, need I say, into this trial, where they received 5 days of treatment, combined therapy with azithromycin, which is an antibiotic, as well as hydroxychloroquine. And with that study, they found that 83% of patients were PCR or negative, tested negative when they swabbed them, again, after treatment with this combination of drugs. However, when you look at what kind of patients they enrolled, most of these patients were much, they weren't as sick as some of the other patients that we've seen with this infection. So only 15% of the patients in their study had fever. And we know that up to 94% of patients that get COVID or SARS-CoV-2 do have fever as a main symptom, but only 15% of their 80 patients had fever. So they're really on a different scale, a different severity scale than some of the other patients we're seeing that are in the ICU, on ventilator, et cetera, et cetera. So first, I will say, obviously we need to replicate this study in a way that it's done, that we prove that it works in a proper way through a randomized control trial and proper scientific method where we have one group that gets a placebo and one arm that gets this combined therapy, but also picking patients that, if they're a little bit on the milder side of the course, like they may have just gotten better regardless of the therapy that you're giving, right? So we need to kind of look at this therapy in a different way. There's a Chinese paper that doesn't get a lot of publicity, but this Chinese paper also looked at the role of hydroxychloroquine in patients. Now, in that study, they used hydroxychloroquine alone, and those patients were more sick. They were in the ICU, and what they showed was that there was no difference in the control arm versus the arm that got hydroxychloroquine. Both of them, within 7 days, were pretty much 93% in the control group and 87% in the virus group, did not have any more shedding of virus. So all of them did very, very well in that small study. I believe there was only 20 patients in that study. So we need to replicate these studies. We're not sure what to make of them. A lot of hospitals are implementing use of hydroxychloroquine right now for treatment of moderate to severe infection. We do believe it has a role in reducing the viremia, but just because your virus levels are reduced, what does that mean for your outcome? We need to measure primary outcomes on these patients and survival rates, basically. So we need to look at this drug a little more closely, and we are in the process of doing that. I know there's a large European study that's looking at, it's a 5-branched discovery trial with thousands of people that will be enrolled, looking at different therapeutic modalities. But, I think people need to realize that this is not a benign drug that we should just be giving to anyone who has suspected COVID, right? Hydroxychloroquine is a drug that has some cardiac side effects. Believe me, I want more than anything for it to be something that works and gets my patients out of the hospital, but we need to use caution with it. So one of the things we need to work on is making sure we're not giving it to patients who have underlying cardiac issues, making sure that their EKGs are very normal before we start them on this drug that could be causing potential side effects if we use it improperly. And the other issue is, people are on this medication for actually other reasons. I have a friend that is taking it for lupus, right? And she cannot get a hold of her medication now because everyone is just calling into their internist to have them prescribe this medication. So I think I just wanted to put, a note out there that we have to be careful with how we use this without sufficient data. So I don't encourage anybody with mild infection to take this medication. Remember, 80 to 90% of people that have COVID-19 will recover without any therapeutic intervention. Some of the other drugs, I know that was a handful, but some of the other drugs we're looking at are remdesivir. So Gilead is offering, now no longer compassionate use of remdesivir. We've moved to several clinical trial sites around the country for remdesivir, which is an antiviral that has been proven to be effective in cases of Ebola, et cetera, in the past, which is a very similar virus. Remdesivir can be used for compassionate use in pediatric patients and in pregnant women if their case of infection is very severe. So please keep that in mind. Some of the other agents that we're seeing some anecdotally good outcomes with, I will mention the IL-6 blockade with tocilizumab. Severe patients with COVID-19 that are intubated, not doing very, very great, they have seen anecdotal good responses with a single dose of tocilizumab. But, each hospital is different, and our country is so, there's a lot of disparity, and some hospitals don't have access to some of these medications. So a lot of them are just offering supportive care and doing what they can with early intubation and proning the patient while intubated. That seems to be helping a lot. So that's my tidbit on therapies, and hopefully more to come.
So wonderful summary of everything that's going on, and there is a lot going on, which in some ways is a great thing because we're going to have multiple potentially different options, but then on the other end, to keep up with all of these developments, because they're, like you're saying, each hospital is doing its thing, so we must be very very involved to make sure we're all on top of this, to make sure we know exactly what is working and what is not. So going along with those lines, in terms of treatments, what about the testing for patients for COVID? Because there has been a lot of development in that regards, and also testing is very important to also flatten the curve and eventually help with overcoming the pandemic, and in terms of long term, we need proper testing to get the economy and people back to work. So what are some of the developments along that line of studies?
Great question. So, I mean, I think testing is such a loaded topic too. That's something that we could have done better. Obviously our country has been a little bit slower to roll out this testing methods, just getting testing available in a broad scale. We can't go back in time, right? So what do we have now, right? So at the moment we have testing available through the traditional PCR extraction methods. And there's many different types of kits, commercial kits available, and commercial labs, as well as public health departments that are being able to do this sort of PCR-based testing through the nasopharyngeal swab. That typically takes 8 to 12 hours for processing and extracting the RNA and amplifying that and getting a result. But we're able to do those types of testing on a bigger scale, so we can run batches of hundreds of samples at the same time. So that's the advantage of that traditional testing that we're really starting to ramp up across the country. But there's also a newer method that's come out that people have been talking about, which is through Abbott Laboratories. So Abbott has created this Abbott ID 100. It's essentially a toaster. It almost looks like a small toaster where you can do almost like point of care PCR testing for COVID-19. So you have to run essentially one sample at a time. So you could only run about 4 samples per hour. It takes 15 minutes for a result to come back, whether it's positive or negative. And this is going to really revolutionize and change things, because we know that people that are COVID positive may not necessarily have symptoms. And if we know that they're an asymptomatic shedder, we can isolate them separately and prevent potential spread that way. Also, screening them, we have issues that come up with pregnant women that need to be screened right away. If they come into labor and they happen to have a fever, we need to know. We have a low threshold for testing in general for pregnant women, but we need to know right away whether or not COVID could be implicated, because then that changes our PPE when we walk into the room, and it changes our complete management for these patients. So this point of care PCR testing with Abbott, I hope that they will be able to deploy these machines throughout the country. I know realistically only maybe some academic hospitals will get access to this initially, but I hope that they will become more widespread in their use. So that's something that's coming up and you should look out for. But also serological testing. So what that means is checking for antibodies against the virus. So usually you check for antibodies about 10 to 14 days after the whole infection is over. During the acute phase of the infection, your IgM will peak. However, your IgG is that long-lasting antibody that infers sort of long-lasting protection against a particular virus. So there's several serological tests that are coming out on the market and that hospitals are going to start using. One of the advantages of using that is I've had countless people tell me, oh, I had this like viral illness in November, December, and I was flu negative, I felt awful, and I recovered from it. So if we can figure out if those people, specifically those that are working in the healthcare field, if they have IgGs that are elevated for this virus, they've survived this virus and they don't even know it, getting those people to be working on the front lines as they are protected against the virus is going to be very key in our combating this. And also the other advantage of figuring out if you have antibodies to this virus is that you could potentially be a donor of plasma serum to others that are very, very sick and potentially save someone's life from giving them some of your antibodies.
So that's exciting because when we were talking about you know, the treatment of modalities, I think the one we didn't get a chance to mention, because obviously there's a lot going on, is the convalescent plasma. Do you mind touching a little bit upon that? Because I know I'm personally very excited about that approach, because immunologically speaking, those are exciting things that I think should pan out. And I know there's multiple institutes that have already started. So can you touch upon that before we go back to the testing? Because I had another question related to that.
Yeah, absolutely. So I think it was March 27th when FDA sort of streamlined the process of getting convalescent serum or serum from those that have survived COVID and giving it to others that are severely infected with this. This is something that we've been doing for decades. And really, even from the Spanish flu of 1918, convalescent serum is something that has been really, really effective. And there are several sites, including Mount Sinai and other hospitals, that are already starting to recruit patients for this type of treatment. And so it's going to be really exciting because this is something that's going to change people's outcomes even before a vaccine is available on a widespread global level. Because as we know, that's still going to take 12 to 18 months to pan out. So this is going to be very key. And the early data, there was one case series that came out of 5 patients in Asia who received convalescent serum, and they had great outcomes. So I think the data for this is really promising, and I'm personally very excited about this, because this is the way that we could get more people better from this virus, and getting our society and economy back on its feet too, potentially.
So these are really 2 key developments, right? Without the serological testing, we would probably not be able to do this. But with the serological test, we might have healthy people walking around now that could potentially be carrying a cure for somebody else, right? So with the serology test, only now we could start doing these on a wider scale. And the more people that recover, the more sort of supply we'll have, as long as people are willing to donate blood.
Yeah, that's so true. And I think that brings me to another question that people have been asking is like, can you get reinfected, right? And what do we know about the antibody response to this particular virus? So the answer is sort of complicated. It's very early to say whether or not you can get reinfected with COVID-19. What we do know is that this virus is not mutating as rapidly as other respiratory viruses that we've seen in the past. So potentially, looking at the SARS data, we know that SARS-CoV-2 is 80% similar to SARS. So looking at the SARS data, people that recovered from SARS, they, remained immune for 2 to 3 years after infection. So that's huge, that is huge. And what we can glean from that also is, or keep in mind rather, is that every single person is going to have a different antibody response to a different virus. So young people might have higher IgG levels to this particular virus than older people, but that potentially we could have longer protection to this for up to 2 to 3 years. That's what many scientists have been talking about.
So that's also very important, because that's something people have been asking a lot, and should they be scared to go out after they've recovered from it? So with the serology, and if it's translated the same way that we know from the SARS data, then things are looking good, right? And we should be a little bit more hopeful that even if we don't have the vaccine ready for the next 12 to 18 months, at least if you've gone through the actual infection, you probably will be protected for another couple of years.
Yeah, potentially. Of course, it's too early to definitively say that, but I think the SARS data is very promising for that. So we'll have to see how things unfold. I mean, I'll remind everyone that it's only been a couple months since we've discovered this virus, and there's still so many unknown questions that we're still learning about. And I feel like the second I read something, the next day it's completely changed. So
yeah, there's definitely no shortage of information that is being thrown at us, and this is why it's so hard to keep track of what's going on. And I can imagine how much more difficult it is for the general public when they're hearing things all the time and things are changing, wearing masks, not wearing masks, reinfection, not reinfection. It's not that there's no answer, it's just the answer keeps evolving. So to keep track of it is also confusing for them. Now, something that I've been asked a lot, and you being a pediatrics infectious disease doctor, what is the sort of overall epidemiological situation here in the US in terms of the pediatric population? And kind of a corollary to that, the second question is, what about pregnant women? What should they be sort of looking out for, and what are some of the data along those lines in terms of being pregnant and being positive for COVID-19? And is there vertical transmission? I know we touched upon that in the very first episode, but has the data changed in any way?
great question. So this is so I'll touch on your last question first. So in terms of vertical transmission, there is no concrete evidence to suggest that a baby can get vertically infected from mother to baby in utero. However, there was one JAMA article that came out. I have mixed feelings about it because this is talking about one particular case where they looked at a COVID positive mother who delivered baby. The baby never had any PCR swabs positive from multiple sites, including different sites like rectum, etc., that were positive for the virus. However, when they checked serologies, they found that the IgM level was elevated in the baby. And why is that important? Well, IgM typically doesn't cross the placenta to the baby. And so that, they said, suggests vertical transmission. I mean, I don't know how to feel about that. It's sort of something that we still need to tease out. I know that IgM actually in certain states of inflammation can pass over through the placenta, maybe not as readily as IgG, but it can be possible. So unless I saw like the amniotic fluid being positive via PCR or something like that, I'm really hesitant to say that there's any true concern of vertical transmission at this point. However, that being said, we're still recommending, and CDC recommends, that moms that are COVID positive be separated from their babies after delivery for a certain period of time. And that's caused a lot of, controversy and angst among the mothers that I've spoken to and whatnot. But this is something that we need to find out more before we can safely keep mom and baby together. The data on pediatric cases is very sparse. We do see some pediatric deaths around our country. So far this week, we've seen a few here in Southern California, 2 teenagers who apparently had a history of vaping, so maybe some underlying pulmonary issue with those patients. However, we've also seen on the East Coast several patients that have passed away that are pediatric patients who had other underlying pulmonary issues and neurological deficits. And to my knowledge, no healthy pediatric host in this country has passed away from this virus so far. So we still have a lot to learn about it. But I think it's because of a child's innate immune response being a little more robust than an older person with other comorbid conditions. Again, we talked about this before. I think that plays a big role in why kids do remarkably better compared to adults and, of course, older adults with heart issues and hypertension, diabetes, etc.
So the numbers are generally consistent with what was initially being reported when all of this pandemic started to happen, right?
Sorry,
In
say
terms
that.
of so the numbers in terms of the pediatric population and the epidemiology of that is generally consistent with what was initially being reported when the pandemic started.
Yeah, so one of the largest, I'll just comment, there was a very large epidemiological study in China that came out that was published recently that looked at over 2,000 cases in pediatric patients. What I will say from that data was that children less than 1 year of age, if they were infected, seemed to have severe or critical infection and did a little bit worse than children that were older. So there's something that we still don't know. Yes, the innate immune system seems to be protective for newborns, etc. But there is potential for children that are young to be really very vastly affected by this infection. So I thought that was interesting. And I know around the country, like the pediatric infectious disease doctors, we've all come together to create a consortium of all of the patients that we are seeing. So hopefully we'll get some more epidemiological data from our collaborations.
What about complications related to pregnancy for COVID positive patients?
Yeah, so the COVID in pregnant women some women seem to do okay, but just as with other respiratory viruses, it's not great to have any sort of respiratory virus when you're pregnant. As your immune system, if you think about it, it's in a way dampened so that you're not, rejecting your fetus, this new um, sort of entity that's being formed in your body. So your immune system has to be dampened in certain ways so it doesn't reject the fetus. Um, and so in that sense, women in general have issues sometimes with respiratory infections like flu. Even when they're pregnant, they have worse outcomes. But with COVID specifically, just the early data suggests that these women can have severe infection and more complications related to their delivery, more risk of postpartum hemorrhage, etc. I know that has been looked at, as well as some moms that end up having to go to the ICU after they deliver, and their hormones and everything is sort of being equalized level care for worsening respiratory symptoms immediately after the delivery. And then some moms that just do great and they have very mild infection. So it's so variable in this population. But in general, I think it's going to be something that we see universally, hospitals moving towards just screening any woman that comes in to labor for the COVID test, just because we need to know if that's a potential issue that we may need to address.
And are I don't know if there's data on it or not, but are people more likely to do, for example, C-sections versus regular birth if they know the mom is COVID positive, or would that not change at all?
Yeah, I mean, it's not like HIV where, we would recommend, or HSV, herpes, right? If there's active lesions, we would recommend that mom gets a C-section to prevent risk of vertical transmission. There's really no recommendation to do C-section over vaginal delivery at this moment. That may change, who knows, once we find out more information, but at the moment, there's no evidence of babies getting the infection through amniotic fluid or the vaginal canal. So again, it's an upper respiratory infection. It's more important that an infected mom take the proper precautions if she happens to be positive and rooming in with her baby. She's wearing a mask during skin-to-skin time and breastfeeding, etc. There's no transmission that we know of through breast milk. So that's very promising, along with, looking at data at SARS, it was never transmitted through breast milk either. So that was, promising too. So I
there
think
is some good news
mostly
in
just
all of
know.
this. So
Yeah, there are some, good things to take home and some silver linings through this.
so speaking of women again, I know there's data showing that they're more resistant to the virus than men. That I think is very exciting because it can uncover potential mechanisms of what this virus is doing. So can you touch a little bit upon that?
Yeah, so this was really interesting to me. When we look at some of the epidemiological data from this infection on a global scale, we find that men and women have pretty much equal rates of the amount of infection. So males are getting infected just as likely as females are. But when we look at the severity and the outcomes, the severity of deaths, so I think the overall rate of death in men is about 2.8% compared to 1.7% in women. So why is that happening? I mean, we still have a lot to kind of figure out, but one of the hypotheses is that females, females contain two X chromosomes, and males contain an X and a Y. Now, the X chromosome is, so the ACE, do you guys remember when we talked about the ACE2 receptors? ACE2 receptor is used by SARS-CoV-2 for entry into our cells, and that gene is expressed on the X chromosome. So what we think is happening maybe is that women that have two X chromosomes are possibly compensating for that bad variant because they have two copies of the X and they're not expressing the ACE2 receptor as much as men who have one X chromosome and one Y. So we will have to figure out what accounts for some of the gender differences in outcomes and mortality in men versus women. That's potentially one of them, but another factor could be that males may have more underlying pulmonary issues, may tend to be more of the smoking population. Another possible factor that we should consider is that there might be some protective hormonal, sort of some protection given through the different hormones between men and women. Could estrogen or other things like that have potential protective factors with this infection? We know women get more autoimmune disorders and things like that, but could there be an advantage in that way too for certain infections? We have to kind of see. Gender differences in general in science are not closely looked at. If you just think about a lot of these mice studies, they either use mostly males, or sometimes when we study certain types of infections, they study, and we want to see behavioral outcomes, we study them on female mice alone. So I think that's important to keep in mind too. There's a lot of gender differences with many different diseases, not just infections, that need to be closely looked at, in my opinion.
But in this case, I think the effect is pretty strong, right, in terms of the gender disparity. And we're talking about mortality rate. We're not just talking about infection rates. So this could actually uncover a potential mechanism of either intervention or understanding of the pathophysiology of this disease. So I think it should be explored very much deeper than what we're just seeing from epidemiological
Absolutely, and I'm sure there are many scientists that are already looking at those differences in mice that get infected with SARS-CoV-2.
Um, so maybe a last question, and if you have any other things that you think I may have sort of missed or not asked you about. One last question that people always ask me is, well, after I get the infection, how long do I have to be cleared, even if I'm um, showing negative on the test, the second test that I do, before I could get to interact with people, right? How long should I feel comfortable after to be able to go on with my own business?
That's a great question. So we're running into how to deal with that question when we see patients in our hospitals recovering from infection and then trying to figure out when it's safe for them to go back to the nursing home or go back home if they've been in the ICU. And typically, we're moving more towards in severely um, COVID patients that have severe COVID and are intubated, et cetera, have a very prolonged course, making sure they have at least 2 negative PCR swabs from the nasopharynx at least 24 hours apart. That's important. But for milder cases, if you have been without fever for at least 72 hours and show improvement in your respiratory symptoms, then you're probably at a point where you're less infectious. Doesn't mean you should be going out into the world and just, you should still be socially isolating for at least a 14-day period of quarantine. But you're probably less infectious, as with many other infections, when you're out of that period where you've had the fever. You're probably shedding more virus when you're having the fever, when it's replicating and your immune system's trying to handle it. So 72 hours without fever and improvement in your respiratory symptoms, still socially isolate and quarantine for at least 14 days. That's what the CDC is recommending at the moment.
Awesome.
I mean, you can still, one thing I'll just mention real quick is that a lot of the data suggests that you can still shed from your respiratory tract for up to 28 days, even after you have the infection in certain cases. So what that means is like, is that virus viable or not to infect other people? It's hard to say because the PCR test is not detecting actively replicating virus or not. It's just detecting the RNA or DNA of that virus, if that makes sense. So, you know, at least 14 days, I would say, to be safe.
So anywhere between 2 weeks to 4 weeks is a good time, and if you can, try to stretch it out to 4 weeks to be absolutely sure, right?
Yeah.
Awesome. Well, this has been really, really awesome. Again, you're doing an amazing job of summarizing all of these vast amount of data that is changing on a daily basis and putting it together in such eloquent way that the people are really learning from it. Do you have any final sort of thoughts before we call it a day for today's episode?
I think we should all continue to socially distance. We are seeing the effects of social distancing in certain parts of the country. And we are in this place where we have different states doing different things, and the majority of Americans now under stay-at-home orders. But really it's working in certain parts of the country, like San Francisco in particular. They had one of the earliest implementations of social distancing and staying at home orders placed. And if you think about San Fran, it's similar to New York in that there's a very high population density and people that are relying on public transportation a little bit more than other parts of the world. So similar to New York in that people are using the BART train, et cetera. And their numbers are phenomenal. Like I think they have less than 1,000 positive cases. So I think social distancing is the only thing that we have to combat this virus. and please encourage you guys to stay home. I know it's really difficult and it feels like we've been doing this forever, but we're literally all in it together. So
Great
keep
point.
doing it.
And we have literally the cure in our hands, and that is our behavior. And the more we continue doing this, sure we'll be over it. And the less we do it, the longer we have to do it, right?
Yes, exactly. So let's just, keep doing it. I mean, we don't have to feel isolated while we do this. And, it's really nice that we have technology and FaceTime and all these other methods to use to stay connected with people that we love. So let's just continue to hold strong, you guys. It's been
Yeah.
really good talking to you, Akop.
Thank you so much. Once again, I really appreciate you doing this. I know you're working hard, long hours, and you're still taking the time to do this. So I truly appreciate it. And I'm sure the people watching it appreciate it as well. And on their behalf, I want to thank you again. So hopefully we'll see you again for another episode in the very near future. And want to wish you a healthy and safe work.
Thank you so much. It was so great talking to you once more, and see you next time.
Bye.
Bye.